Okay. ഓക്കെ മാഡം, നമുക്കൊരു 2 minutes വെയിറ്റ് ചെയ്യാം മാഡം. കേൾക്കുന്നുണ്ട്?
Okay, okay.
ഓക്കെ ആണ്. ഓക്കെ. ഇൻസെറ്റ് ആകാൻ പോകുന്നത് കൊണ്ട് കുട്ടികളെല്ലാരും ഇൻസെറ്റിന്റെ പറയാണ്. ഇൻസെറ്റ് ആണ് ഈ മാസം. അപ്പോ
Okay.
അതിന്റെ ഒരു ഇതുണ്ട്. പിന്നെ ക്ലാസ് ഒക്കെ തീരാൻ പോവുകയാണ്. അപ്പൊ അതിന്റെ കുറെ ഇഷ്യൂസ് ഉണ്ട്. പിന്നെ നമ്മുടെ ക്ലാസ്സസ് വി ആർ റെഗുലർലി നമ്മൾ കൊടുക്കുന്നുണ്ട്. ചില ക്ലാസ്സുകൾ അപ്ലോഡിങ്ങിൽ ചെറിയ ഡിലേ വരും. അപ്പൊ ഇന്നിപ്പോ
Okay.
ഇത്രയും ദിവസത്തെ ഓക്കെ ആയിരുന്നു. ഇനി നമുക്ക് ലാസ്റ്റ് ഒരു 4 ക്ലാസ്സസ് ഉണ്ട്. അതിന് നമുക്ക് കുറച്ചൊരു ഡിലേ എക്സ്പെക്ട് ചെയ്യുന്നുണ്ട്. എന്നാലും നമ്മൾ മാക്സിമം ട്രൈ ചെയ്യുന്നുണ്ട്. പിന്നെ
Okay.
റേഡിയോ ഡയഗ്നോസിസിന്റെ കാര്യം പറയുവാണെങ്കിൽ കഴിഞ്ഞ പ്രാവശ്യത്തെ ക്വസ്റ്റ്യൻസ് ചെക്ക് ചെയ്തവർക്ക് അറിയാം. അത് മാഡത്തിന്റെ ക്ലാസ്സസ് റിലേറ്റ് ചെയ്ത് കുറെ ക്വസ്റ്റ്യൻസ് ഉണ്ടായിരുന്നു. അപ്പൊ
Okay.
അതുകൊണ്ട് അതേ പോയിന്റ്സ്, ഒത്തിരി ക്വസ്റ്റ്യൻസ് പോയിന്റ്സ് ഉണ്ടായിരുന്നു. വളരെ യൂസ്ഫുൾ ആയിരുന്നു ക്ലാസ്സസ്. അപ്പൊ
Okay.
അതുകൊണ്ട് യൂഷ്വലി ഇതിന് മാത്രമല്ല മറ്റ് ക്ലാസ്സുകൾ മറ്റ് വിഷയങ്ങൾക്കും എല്ലാം കണക്റ്റഡ് ആയിട്ട് കുറെ പോയിന്റ്സ് കിട്ടുന്നുണ്ട്.
Okay.
ആൻഡ് മാഡം ഒത്തിരി വർക്ക് ചെയ്തിട്ടാണ് വരുന്നതെന്ന് അറിയാം. സോ ദീസ് ക്ലാസ്സസ് ആർ വെരി ഇമ്പോർട്ടൻറ്റ് ഫോർ അസ്. സോ വെരി ഹാപ്പി ടു ഹാവ് യു ഹിയർ. നമുക്ക് എന്തായാലും ദീസ് ക്ലാസ്സസ് ആർ എഡിറ്റഡ് ആൻഡ് അപ്ലോഡ്. അപ്പൊ അതുകൊണ്ട് നമുക്ക് സാധാരണ കറക്റ്റ് ആയിട്ട് നമ്മൾ തുടങ്ങുന്നത് നമ്മളൊരു 5 minutes കുട്ടികൾ ജോയിൻ ചെയ്തോളും. ആൻഡ് ഈ ടൈമിംഗ് ഇപ്പോൾ ഈ പറഞ്ഞ പോലെ തിങ്കളാഴ്ച ദിവസമൊക്കെ കുറച്ച് ട്രാഫിക് ആയിട്ടൊക്കെ ഡ്യൂട്ടി കഴിഞ്ഞ് വീട്ടിലെത്താനൊക്കെ കുറച്ച് ഡിഫിക്കൽറ്റി ഉണ്ട്. സോ ദേ വിൽ ജോയിൻ. സോ
Okay.
നമുക്ക് കറക്റ്റ് ആയിട്ട് സ്റ്റാർട്ട് ചെയ്യാം.
Okay.
ആൻഡ് ദ റെക്കോർഡിംഗ് ഈസ് ഓൺ. അപ്പം ഇന്നത്തെ ക്ലാസ് നമ്മുടെ ടുട്ടു മാഡം ആണ് എടുക്കുന്നത്. മാഡം വളരെ പാഷനേറ്റ് അബൌട്ട് ടീച്ചിങ് ആണ്. ആൻഡ് ഇൻ സ്പൈറ്റ് ഓഫ് ഹർ ബിസി ഷെഡ്യൂൾ ഷീ അഗ്രീഡ് ടു ടേക്ക് ക്ലാസ് ഫോർ us. So IMA is indebted to her. And we want young doctors like madam to come to this field and share their knowledge. And ഇത് ശരിക്കും നമ്മൾ ജൂനിയർ ഡോക്ടർ നെറ്റ്വർക്കിൽ തന്നെ ആദ്യമായിട്ട് നമ്മൾ പുതിയ പുതിയ ആളുകളെ കൊണ്ടുവരണം എന്നാണ് നമ്മൾ ഉദ്ദേശിക്കുന്നത്. സോ her name was suggested by a very good friend of mine. So last time also we're very happy that madam took class. So over to you madam. നമുക്ക് തുടങ്ങാം.
Okay. So yeah, good evening to all. Thank you, Swapna, for that kind introduction. So today we are going to discuss MCQs from the topic of radio diagnosis. And before starting off, let me thank IME for giving me this opportunity for the consecutive time, for the second time in a row. And yeah, about radio diagnosis, one thing is that we unfortunately are not a lot exposed. We don't have a lot of exposure in radio diagnosis during our undergraduate days. So definitely this is going to be a little difficult compared with the other clinical and the non-clinical subjects, which we do have a lot of exposure in our undergraduate days. So what I'm trying to do is here, I have divided the radio diagnosis, the topic, into several different systems, and I will be discussing MCQs in each of these systems. So we have this time constraint of like 2 hours, and I'm not sure if I will be able to finish the whole presentation in a single go. We will try to move quickly from one question to another so that you will just get an idea of what all are the possible topics and how you can think about when you see an image. So after discussing, maybe if you get an image, how to say whether this is particular image, what they might be asking. So most of the questions, if you put the whole thing into a perspective, you will be able to at least eliminate a few of the choices. So basically just being quite, they will be giving a lot of these, what we call as some kind of keywords and all. So you have to identify from those keywords that this might be related to this particular thing. So in that way also you will be able to, at least you will be able to shortlist a few of the options, and maybe with some understanding of the topic, you might be able to come to a conclusion as this must be the option for this. I mean, this must be the answer for this. So without any further delay, let's move to the first system. So this time I will be starting from a few MCQs from the CNS. So let's start with a simple question. Which of the following is the best choice to evaluate radiologically a posterior fossa tumor? So basically, among these options, angiography, that is kind of a very general sort of a thing. Myelography, it is not used a lot these days. Myelography, as the name suggests, it's mainly to look into the spinal canal, to look into the spinal lesions and all. But the contrast myelography, the contrast being injected into the subarachnoid space through a lumbar puncture, these are not usually performed. So the best choice to evaluate, definitely it is going to be a cross-sectional study. It could be a CT scan or MRI. So among which, when it comes to a posterior fossa tumor per se, what happens is that the posterior fossa, the one that is having the brainstem, the cerebellum and all, so this area is quite a crowded space. So when it comes to CT, this crowded small space is surrounded by a lot of bones, and it gets disturbed by a lot of artifacts. So if we need to study a tumor, as a lesion, even an infarct for that matter, sometimes a CT wouldn't be that helpful. So you might be able to say that there is something there, but then it might not help you more than that. So when it comes to a posterior fossa tumor, with an MRI, you will be getting a better resolution of the posterior fossa structures, be it the brainstem, be it the cerebellum, be it the other vascular structures surrounding it. So all these will become much more easier and much more readily, very clearly visualized when it is a MRI. So obviously the answer for this question is an MRI. Now with that, next question, 60-year-old male smoker, hypertensive. So a lot of risk factors, presented with a left-sided hemiplegia. What is the diagnosis based on this CT? So actually speaking, even if we do not have this image also, we definitely know that based on this question, based on the pattern of this question, it is something related to a CVA. So that is quite sure. The patient is having a left-sided hemiplegia. So we are expecting the pathology, whatever it is, on the right side. So this is a CT that you're seeing on the right side of your screen. And what is this CT showing? Basically, I hope my arrow is visible over here. So yeah, this is a wedge-shaped area of hypodensity. So just a heads up, like in CT, whatever it is, we use the term dense. So it could be hypodense, it could be hyperdense. If it is hypo, what we mean is it is more towards the gray color. It is more towards the black color. That is how it is. So that is when we call it as hypodense. Whereas when it is more white, as the maximum white as you get in this cortical bone, it will become hyperdense. Okay. So hyperdense means it is more of a more of towards a shade of white, and the hypodense is more towards the shade of black. So in CT, the particular term that you use is dense. Whereas when it comes to MRI, same thing. Hyper more of a whiter shade, and hypo more of a darker blackish shade, to make the things more simple. And the only difference is that you put the term intensity when it comes to MRI. So in MRI, it is intensity. In CT, it is density. When it comes to an X-ray or a radiograph, we put the terms like opacity and all. Okay, opacity, lucency, likewise. So anyway, so this is a wedge-shaped area of hypodensity. It is so basically, in the annotations, this side will be the right side. The patient is as if you are seeing the patient. The patient is standing in front of you, or the patient is lying in front of you, and this side will be the right side. So mostly they would have put the annotation as if whether it is right side or the left side. I hope that in the exam questions, if at all the side is important in that particular exam, definitely they are going to mark it as right or left, because it can change. So it's normally it is universally it is like this side is going to be the right side of the patient, and this side is going to be the left side of the patient. But however, for an exam scenario, if at all it is important, definitely they will mention the side. So okay, so based on which I'm telling that this is on the right side, there is a hypodensity, which is looking like a wedge-shaped hypodense area, which is involving the right frontal as well as some of the parietal region. So this hypodensity is because of what? This is because of an ischemic infarct, right? And apart from that, you can see that when compared to this area, these are the sulcal spaces. So here, these sulcal spaces are all effaced. Not just that, you can see that this is the lateral ventricle, which is on the left side. The lateral ventricle can be clearly seen, but what has happened on the right side? The lateral ventricle has got compressed, or it has become effaced. So this is because of the mass effect. This is because of the edema that has developed, the cytotoxic edema which has developed. So this is nothing but an ischemic infarct. So SH, we will see a bit of SH when we go through the slides. So lacunar infarct, on the other hand, it is also a small infarct. The difference is that it is a small infarct. It's a smaller sized infarct, maybe like just a point. So that is how a lacunar infarct will look like. So this is kind of a very large infarct, which is in the MCA territory, in the right MCA territory. So this is an infarct which has very well evolved, and that is why you are able to see it without any confusion in a CT. But if you are asked, what is the, maybe if the patient is coming with all these symptoms, and if you want to, if you are asked what is the first investigation of choice, it is, the time is very crucial. And if you are having, if the patient is coming really in the window period and all, if you want to rule out that there is a hemorrhage, because that is an important thing to be known before starting off the treatment. So in such a situation, it is CT, because CT can be done very fastly in and out. The patient can be taken in, taken out in a very, in a matter of a few minutes, and hence the investigation of choice would be when the time is important in order to rule out the hemorrhage. If that is what you are looking for, then CT would be the choice. But the thing with CT is that in the first 6 hours or so, an infarct may not be visible. So this is very starkly clear, right? But then this might not be the case in every infarct that is coming. So there are certain hyperdense, hyperacute signs which happens, which when this infarct is not evident like this. So it may be just that the insular ribbon is effaced, or there is a hyperdense MCA sign. So likewise, there are a few signs which are associated with the hyperacute infarct. But on the other hand, there is this investigation, that is MRI, which can help, which can be helpful in telling that there is an infarct in the very first place. So if there is if we have to rule out whether there is an infarct, then MRI is the ideal choice. In MRI, the diffusion weighted image. So first of all, the answer to this question is an ischemic infarct, and coming to an MRI, the sequence, this particular sequence is called as a diffusion weighted imaging. And in this diffusion weighted imaging, even before the infarct becomes evident on even the other sequences of the MRI or in a CT, the diffusion weighted sequences can show the infarct pretty quickly. So this is the diffusion weighted imaging sequence from an MRI, and that can show the infarct like this hyper intensity. This is a hyper intensity because this is an MRI diffusion weighted sequence. So this can show. If you want to find out the penumbra, which is that ischemic zone but not yet infarcted. So if you want to see that ischemic penumbra, then you have to do a perfusion study. It could be a CT perfusion or an MRI perfusion study, which will help you in also deciding how much is the penumbra and if there is a mismatch. So that will also help, or that will also guide the type of treatment for that particular patient, right? And if we want to know exactly what has happened to the vessels, we need to go for angiography. It could be a CT angiography or an MR angiography. The advantage with an MR angiography is that in MR angiography, it could be done even without contrast. Otherwise, an angiography is always a contrast procedure. And for CT angiography, always a iodinated contrast material is used. But in MRI, it could be a contrast study also with gadolinium-based contrast agents. But on the other hand, it could be done with specific techniques like time of flight angiography is there, where there is no need of a contrast. So it could be done even when the patient's renal function is not good. Now, next question, tumor showing a dural enhancement with a tail is. Okay. So certain tumors, they show this dural enhancement along with the tumoral enhancement, and it has got this characteristic tail-like appearance. So among these options, meningioma, that is the one which typically will show a very good dural tail. So this is how this dural tail looks like. So this is basically an MRI. This dural tail may be seen even when in a good CT, in a CT contrast study also, this dural tail will be seen, but then this is more evidently seen on a MRI. So in this MRI, this is a T1 post-contrast sequence, and this kind of a sequence is the coronal sequence, and this is an axial sequence. Okay, so this is the lesion that has got enhanced. It is an extra axial lesion, which means it is outside the brain parenchyma. But and this is what we call as the dural tail, right? So the dural tail is not, it is not specific for a meningioma, but then meningiomas are one of the most common tumor which shows this dural tail enhancement. So there is some dural enhancement which is present, and it has got this tail-like appearance. But it can be seen in other lesions like in when there is a dural metastasis, when there is sarcoidosis, and in tuberculosis, even in some cases of gliomas, all we can get a dural tail. So it is not specific, but then it is very commonly seen with meningioma. Coming to the next question, this is an MR angio of a child who presented with hemiplegia and past history of recurrent fainting spells. What is this showing? So basically, this is an image from an MR angiography, right? And what is shown here is this is the contrast opacified internal carotid arteries. But beyond this is the right and this is the left. Okay, so beyond a particular point, the internal carotid artery is not seen like the way we are seeing it over here. So this is the cervical part, and these are the different segments of the bilateral internal carotid artery. So somewhere at the supraclinoid level onwards, we are not really able to make out the internal carotid artery, not just the internal carotid artery, also the circle of Willis. So this is a particular condition which is a non-inflammatory, non-atherosclerotic vaso-occlusive condition, which is called as the Moyamoya disease. Okay, so in this Moyamoya disease, there is slow progressive occlusion happening to the ICA as well as the circle of Willis. It typically happens from the supraclinoid level, and then it also involves the circle of Willis. So what happens is that this patient will be having hemiplegia, and because of the slow progressing nature of the disease, there will be multiple small collaterals which is developing. So these small collaterals will develop from the lenticulostriate vessels, from the different vessels. It must be from the pile vessels. So many from the different vessels. So many collaterals will develop, and this is all these collaterals that you are seeing, which is giving what is called as a puff of smoke appearance, right? So this is the case of a Moyamoya disease. Okay, so let me also take you through this particular case. What is this? This is not Moyamoya. So I'm just going to describe what is called as the vein of Galen malformation, right? So here you are seeing a CT post-contrast image in the sagittal section. So I just showed you a coronal section and an axial section. So this is what is called as a sagittal MPR, or a sagittal reformat. Okay, and in this particular case, this is a CT, and here this is another volume recon. And okay, what is seen here is an extremely dilated vessel in the midline, right? So this is nothing but this is called as the vein of Galen, which has got enlarged. Okay, so this vein of Galen malformation is actually what happens here is the median prosencephalic vein. There is something which is called as a median prosencephalic vein, which is a embryonic precursor of vein of Galen, right? So what happens is that there is some sort of connections in the embryonic period between these the so-called median prosencephalic vein and the choroidal arteries. Initially, it is the choroidal arteries that is mainly supplying the brain parenchyma. So these connections, they do not get obliterated, or they just persist from 6 weeks and onwards. So what happens is that from the high pressure system to the low pressure system, the blood is continuously shunted, which results in this aneurysmal dilatation of this vein of Galen, or the median prosencephalic vein. So that is what is called as a vein of Galen malformation, right? So again, this is the vein of Galen malformation that we are talking about. And these children typically present in the early life itself with congestive cardiac failure because of this high cardiac output state. It's a high cardiac output state, and therefore these children present with a congestive cardiac failure. Okay, so this is how a vein of Galen malformation will look like. And this is just in utero antenatal image of a baby, which is again showing this dilated vein of Galen, right? This is a grayscale image. This is what we call as a grayscale image, and this is a color Doppler image. Moving on to the next question. Characteristic finding in an MRI scan of a patient with tubercular meningitis. So tubercular meningitis, so the TB in the brain can involve different parts of the brain. So one of the most common location is the meningeal involvement. It happens as a hematogenous spread mostly from a pulmonary tuberculosis. And the tubercular meningeal involvement is mainly with the presence of okay, what they are asking about the characteristic finding. Maybe you can see all these findings, but the characteristic finding is the presence of exudates within the basal cistern. As you can see here, there will be the TB exudates, which is seen within the basal cisterns, the interpeduncular cistern, in the basal cisterns, along the middle, along the middle cerebral artery. So this is what happens here, and it can ultimately result in obstructive hydrocephalus. It can cause arteritis. It can lead to vaso-occlusions. It can lead to arthritis, and thereby can cause infarct. So this is the most common finding. Maybe it can also cause some amount of ependymitis or the ventriculitis as well. But when you are asked the characteristic finding, that would be the exudates in the basal cistern. Okay, now another entity which is called as a subclavian steal syndrome. Which of the following statement is true regarding the subclavian steal syndrome? So in the subclavian steal syndrome, let me just tell you what is a subclavian steal syndrome. So in subclavian steal syndrome, what happens is that there is there is shunting of the blood from the vertebral artery, that is from the intracranial circulation. It is being taken into the upper limb because there has been an occlusion in the proximal subclavian artery. It has occurred before the origin of the vertebral artery. So when there is an occlusion within the proximal part of the subclavian artery, what happens is that, especially when the person is exercising, whenever the upper limb is exercising, what happens is that from the vertebral artery, the blood will flow back into the subclavian artery into the arms. So how will it be seen? So normally there is a flow pattern. There is a normal particular flow pattern in the vertebral artery of the same side, which is expected to be always in the positive side. But when there is a reversal of this blood flow, which is occurring through the ipsilateral vertebral artery to go into the subclavian artery, what happens is that there will be reversal of blood flow in the ipsilateral vertebral artery. So what happens is that the patient can develop the ischemic sort of symptoms, especially when the patient is exercising. But it also, sometimes the patient can remain asymptomatic also, especially when the posterior communicating artery is patent and if it is doing a good job, the vertebral artery will not be having a lot of, or the vertebral artery, even when there is a subclavian steal, the vertebral artery can do its job normally. So the patient might not have a cerebral symptoms. Otherwise, these patients will be having CNS ischemic symptoms. So let's see. So this is an MR angio image for you. And here you can, what you're seeing here is, okay, so okay, as shown by this arrow, there is a tight stenosis which has happened in the proximal part of the subclavian artery on the left side, and from here the vertebral artery is going up, and this is a subclavian artery, right? But based on this MR angio, we are not able to tell whether there is a subclavian steal happening in this patient. So there comes your simple Doppler. So this is basically a carotid artery or the neck vessel Doppler, which has been done for a particular patient. And this shows that, so we are looking whether there is a steal phenomenon, subclavian steal phenomenon happening on the left side. So this is a normal left common carotid artery with a normal waveform. So this is the baseline, and this is the waveform which is going all in the upper part of this baseline, or otherwise this is a normal positive spectrum of the common carotid artery. Now, if you see, this is the right vertebral artery for your comparison. This is the normal spectrum of a vertebral artery. Okay, so this is how a normal vertebral artery should look like, and it should be having the flow above the baseline. So this is the normal vertebral artery spectrum which is present on the right side. Now you look into the left vertebral artery. You can definitely tell that these two spectrum doesn't look the same, right? So the left vertebral artery, it has got a difference in its spectrum with some of the flow which is going below the baseline. So this shows that there is a subclavian phenomenon. Okay, so when there is a partial steal, there will be some part of the flow which is maintained above the baseline and some part which is going below the baseline. So it is somebody think that this looks like a bunny or a rabbit. So it is also called as a bunny sign and all. Anyways, when it is a complete steal, what happens is that there will be complete reversal, or the entire spectrum will be below the baseline. Okay, so that's it. Okay, so this is showing that subclavian steal phenomenon on the left side because of this tight occlusion which is present in the proximal subclavian artery. Now, this is something which is called as a ring enhancing lesion. So the ring enhancing lesion on a brain scan. So this is again an MRI of the brain, T1 weighted image, T1 post-contrast study. So it is on the T1 sequence, that a post-contrast. After the administration of contrast, we take a T1 weighted sequence. Okay, in MRI, there are different sequences which is done: T1, T2, flare, diffusion, perfusion, etc. So the post-contrast is a T1 weighted sequence. So in this T1 weighted sequence, you are seeing here, there is something which is enhancing. Whatever is the enhancement is the one that you are seeing white in color, right? So this is having a ring. There is a lesion over here and it is showing the ring-like enhancement. So this suggests what? Abscess, metastasis, is it a glioblastoma, or whether this could be all of this? So actually, this is anything. It could be either of these. Okay, so all of the above is the answer in this case. So coming to that takes me to this particular mnemonic, Dr. Magical. So in MRI, ring enhancing lesion is a very important entity to be known, and these are the conditions which can produce this ring enhancement. Okay, so that is Dr. Magical. Demyelinating diseases like multiple sclerosis, especially, it will cause an incomplete. So this is a complete rim. Okay. Whereas in a demyelinating disease, classically it is an incomplete rim of enhancement. R stands for a radiation necrosis, or it could be even with a resolving hematoma, which can show a ring-like enhancement. And then it could be a metastasis, it could be an abscess. These, the one I have written down in the red color, these are something more important. Okay. All the conditions which we see in a more regular basis. It could be an abscess which can show this rim enhancement, glioblastoma, subacute phase of an infarct, not all infarct, but a subacute infarct. Even a contusion can show it. AIDS-related CNS diseases, lymphoma. So these are the group of conditions which can show you a ring-like enhancement. So when it comes to a real-life scenario, sometimes it becomes difficult, but then everything is not made on a single picture, no? So we have the history with us, we have the previous imaging with us. Then we also look into the different sequences, and then we will make a conclusion as to what is the first possible diagnosis and what are the differentials. So it's not that easy as it sounds, but with the help of all these, when everything is put together as a clinical radiologist, not by looking just into the images, but by asking the history, by looking into the sequences, looking whether there is central diffusion restriction, so many different things can be put together, and then we can possibly come into a conclusion. So now, the next question, the CT scan showing a subarachnoid hemorrhage following symptoms of sudden headache and paralysis. The next investigation of choices. So the basic outline of the question itself, the sudden onset of headache followed by which there was CT done, which shows subarachnoid hemorrhage, that does ring a bell, right? So it says that there has been an aneurysm which has ruptured. So in such situation, what is the next investigation of choice? So the CT itself would have shown subarachnoid hemorrhage, and if it is a plain CT, it is not going to show you exactly the aneurysm. Maybe based on where this subarachnoid hemorrhage is mostly localized, we will be able to somehow say that this could be because of this particular aneurysm, this could be because of an ACOM aneurysm, like that. But if you want to basically look for which is the aneurysm which has ruptured, and if at all the patient requires a treatment in the form of a coiling and all, what is the investigation? So the next investigation would become a 4-vessel angiography, or a DSA, is what is done. Transcranial Doppler, just by doing an MRI, it is not going to help you out. So also SPECT is not out of question in this particular question. So it's basically the 4-vessel angiography. Okay. So that's a nutshell about CNS. I think a few more questions come here and there in some other systems also. Let's move on to a different system now, that is MSK now. So the question 1, a 40-year-old female on long-term steroids presenting with recent onset severe pain in her right hip. Imaging modality of choice for this problem is, so basically based on this question, it doesn't tell you what is the thing that you are expecting here, or what is the diagnosis. They are not telling this patient is having this, you need a particular investigation. You have to find for yourself what this patient might be having, and then you have to think what will be that investigation which is going to help you. So there are some buzzwords like long-term steroid therapy, sudden onset pain and all in the hip joint. So everything points towards avascular necrosis of the hip joint. So for an avascular necrosis of the hip joint, now the question is like this. Avascular necrosis of the hip joint is there. So what is the imaging modality of choice? So let me ask you, whether it can be seen in a plain X-ray? It could be seen, but only if it is progressed to such a it is kind of a very chronic AVN. It has gone to some stage 4 or so, then it will become quite evident in an X-ray. But that is not the case here. So in such situation, it is going to be the MRI. So even if it is a bony pathology, it is not a CT scan which is going to help you, because initially it will be some marrow edema and certain simple findings that is going to be there. Only such findings will be there. So in order to look into the marrow, it is going to be the MRI that is going to help you. So in this particular case, it will be the MRI that is the imaging modality of choice. We're not expecting a simple fracture. So if it were a fracture, definitely a CT would have helped. Okay, but that is not the case. In order to pick that mere marrow edema, MRI is the investigation of choice. Now, coming to another important entity, subperiosteal erosions is seen in which of these conditions? Scurvy? Is it in scurvy? No. Is it in hypoparathyroidism? No. Is it in rickets? No. So this is hyperparathyroidism, the option B, which shows the subperiosteal erosion. So when it comes to hyperparathyroidism, there are a lot of systems which are involved in with the hyperparathyroidism. There can be some CNS symptoms, there can be abdominal pain, and there can be bone pain. So all a cluster of symptoms can happen with hyperparathyroidism, and a lot of skeletal findings are there associated with hyperparathyroidism. Now, in hyperparathyroidism, the primary, secondary, tertiary, different types are there. Primary, most common one, and that is because of a parathyroid functioning adenoma. That is the most common cause of a primary that is the cause of a primary hyperparathyroidism. When there is a here there is this parathyroid adenoma, it is functioning, and that results in increased bone resorption. The calcium levels are increased, the alkaline phosphatase is increased likewise. Whereas in secondary hyperparathyroidism, it is when there is an underlying renal pathology, and because of which the calcium levels in the bone is in the body is low, and so what happens, there is increased activation of the parathyroid glands, and that is when you get a secondary hyperparathyroidism. Since the renal function is poor, the phosphate levels will be also increased in a secondary hyperparathyroidism. Okay, and tertiary is when there is a autonomous development of a parathyroid adenoma. Okay, in the secondary, it is more or less like a generalized activity of the gland, but then in tertiary, because of the chronic irritation of this parathyroid glands, because of the underlying renal impairment, finally it will lead to the development of a parathyroid adenoma on its own, and that is called as a tertiary hyperparathyroidism. So these are the different types of hyperparathyroidism. So with this increased amount of parathormone, what happens is that there is several type of resorptions which is happening. It could be subperiosteal, name a few. It could be a subperiosteal resorption. It could be a subligamentous resorption, subchondral resorption, trabecular erosion. So many erosions are happening here. And just one point to add is when there is a secondary hyperparathyroidism, if it is due to a secondary hyperparathyroidism, you will also see some soft tissue calcifications. So these are soft tissue calcifications are more commonly seen with secondary hyperparathyroidism. It might not be seen in a primary. So with that, let's see what is happening here. So if you can see here, just see. Okay, very evidently you can see this is what is called as the subperiosteal resorption. Okay, this appearance, which is called as a subperiosteal resorption. So it most commonly is seen within the proximal phalanges as well as in the middle phalanges of the second, third, fourth digits commonly. So this is what is seen in this particular case, and that happens with hyperparathyroidism. Let's see a few more skeletal findings with a hyperparathyroidism. This is the so-called Rugger jersey spine. This is seen with a renal osteodystrophy, which result in secondary hyperparathyroidism. So this is called as a Rugger jersey because it resembles a Rugger jersey. And what has happened here? There is increased sclerosis of the vertebral end plates. So there is sclerosis, then there is some lucency. There is sclerosis, then some lucency. So this alternating bands which give rise to this sort of appearance, which is called as a Rugger jersey spine. Now, why I have put this particular radiograph here. So in this radiograph, what is striking is you are not seeing some of the distal phalanges, right? So this is what is called as acroosteolysis. There are a n number of causes for acroosteolysis. One important cause being hyperparathyroidism. And again, this patient is also a secondary hyperparathyroidism. Why I say that? Here you can see something. This is actually a fistula. This is actually a fistula that has been created for this patient who is on hemodialysis. So this patient is having a chronic renal disease, and then that has resulted in secondary hyperparathyroidism, and that has resulted in acroosteolysis, which is also a finding in hyperparathyroidism. Now, what is this? This is the skull finding, very commonly asked question, that is the salt and pepper. It looks like we have just sprinkled some salt and pepper over the skull bone. So there is very small lucencies over the entire skull bone. This is a lateral view, by the way. And also there are multiple small dense areas, sclerotic areas and lucent areas are seen diffusely in the skull bone. So this is because of this trabecular erosion which is happening in the skull bone. Apart from that, there can be erosion of the lamina, dura, all these can happen. Okay, so that is that. Okay, now one more radiograph. So what does this radiograph show here? So there are some other things. Let me take you through this. So this is this pacemaker, which is seen. It is normal. And apart from that, there is the central line, which is going with the tip in the region of the superior vena cava. Yeah, and this is another line which is through this subclavian vein. So all these things are there. Now I want your attention to go to this place. Okay, so this is the lateral end of the clavicle. This doesn't look normal. The lateral end of the clavicle has got some osteolysis over here bilaterally. So one important cause being hyperparathyroidism. Then rheumatoid arthritis is another important cause which can result in osteolysis of the lateral end of the clavicles. It could be also because of infections. It could be because of a trauma the patient has undergone. It could be because of some trauma, infections, tumors. All these can produce, but then the two important classical conditions which can result in erosion of the lateral end of the clavicle is hyperparathyroidism and rheumatoid arthritis. Okay, in this patient, there is one more finding which helps you to tell that this is probably due to hyperparathyroidism. Well, here, these are the surgical staples in the region of the neck. And this was because the patient was operated for a parathyroid adenoma in the past, right? So it indirectly tells you that this patient has had a parathyroid adenoma, which was the cause of this hyperparathyroidism, and that has resulted in so-called erosion of the lateral end of the distal end or the lateral end of the clavicles. Now coming to vertebra plana. What is vertebra plana? Vertebra plana is when there is complete flattening of the vertebral body. Okay, there is loss of the vertebral body in its anterior as well as in its posterior aspect. So it looks like a plate. So that is what is called as a vertebra plana. So there are typically a set of conditions which can result in vertebra plana. And among these, all these conditions can cause a vertebra plana. So when it is a child, it is the eosinophilic granuloma that is a very important cause which can result in vertebra plana. See, this is the vertebra plana. Okay, just compare it with these two vertebra above and below, and then you can see that this vertebra has just been collapsed, like it has been converted into a vertebra plana. So this can happen with, you can just remember it as eye melt. In which I stands for infection. So any sort of infection can do anything to the bone. So it could be an infection, okay, which has resulted in that collapse of the bone. Then M stands for this metastasis, multiple myeloma, especially in an adult. Then E stands for this eosinophilic granuloma. L stands for leukemias, and then T for trauma, tuberculosis, like that. Okay, so in a child, think about eosinophilic granuloma, even leukemias also for that matter. But then eosinophilic granuloma is very, very, very like a favorite thing about when it comes to a vertebra plana. Okay. Now this is what is called as a hair-on end appearance. Okay, so this is the hair-on end appearance in a skull X-ray. So what happens here is there is the perpendicular appearance of this trabecular bone that you are seeing here. And this happens in a case where there is marrow reconversion, which occurs with a hemolytic anemia. So the marrow has got activated, and that is why this particular appearance has happened. Okay, but all these choices are hemolytic anemias, right? Or at least they all cause anemia, but then among which characteristically it is seen with thalassemia. It can be seen in these conditions too, but if it is asked as the characteristic, it is related with the thalassemia. So this is the MRI sagittal sequence, which is showing the same hair-on end appearance. And these are the causes, okay? So all these can cause, but then thalassemia is the most important cause that you have to remember when it comes to hair-on end appearance. Okay, now coming to another important heading, that is champagne glass pelvis is seen with. So this champagne glass pelvis is a appearance that is seen in this pelvic inlet over here. And this is typically linked with a skeletal pathology called as achondroplasia. So this achondroplasia, it is the most common skeletal dysplasia. And they will be having, these are the most common skeletal dysplasia. And also the important thing is that they will be short statured, but they will be having normal IQ levels. They will be having normal motor activity functioning level, but at the same time, they will be having some delay in their milestone. The motor milestones may be delayed, but then ultimately they will be having all normal gross motor activities. So there are a lot of there are a lot of bones which are affected in case of achondroplasia. It happens because of a mutation that happens in the fibroblast growth factor receptor. And this can involve multiple bones in the body. In the skull, it can cause narrowing of the foramen magnum. So these patients, they can present with cranial nerve involvement, neurological deficits. So all these things can happen in case of achondroplasia. Apart from that, in the vertebrae also, there are some findings which I will show you in the next image. So in the pelvic bones, one is the champagne glass inlet appearance. Another one is this particular appearance of the iliac bones. The iliac bones will be little smaller in size, and it is called as a tombstone appearance, otherwise called as a Mickey's ears appearance. Okay, so that is one appearance which is there. And then the acetabulum, it is going to be more flattened. There is something which is called as trident acetabulum. So there are not so many name signs. I will just take you through a few findings in achondroplasia. So one important findings, especially in the vertebra, is this what is called as this is what is called as a posterior scalloping. Okay, so the spinal canal is narrowed, and that because of the pedicles are very small, so the spinal canal ultimately becomes narrowed, and it also causes this scalloping of the posterior margin of the vertebra, otherwise called as the posterior vertebral scalloping. One important cause to remember being the achondroplasia. Then apart from that, okay, so this is the upper limb, and in this upper limb, the long bones, the proximal long bones are shorter compared to the distal long bones. This is called as a rhizomelic pattern of dwarfism. So this is a rhizomelic dwarfism that you are seeing here. And then if you look into these fingers, what you can see is that they will be having like short stubby fingers, and they will be arranged in this what is called as a trident axis, which means normally what we call the ring finger and the middle finger, they will be somewhat near to each other. But then in these patients, the ring finger and the middle finger, they will be away from each other. So it looks as if they are having three axes. Okay, so you can just Google the image of a trident and see what is meant by the trident. Okay, so anyways, this is how the trident appearance will look like. And this is the tombstone appearance or the squaring of the iliac bones that I was mentioning. And apart from that, there is also some very important finding, that is the interpedicular distance gets narrowed. Okay, so there is a narrowing of the interpedicular distance, which is more evident in the L5, S1 level. So that is also one important finding which is seen in a case of an achondroplasia. So these are some skeletal findings which are seen, and they mainly present with these conditions of some neurological deficits. It's because they are the small bony foramina through which the nerves are exiting. All these gets narrowed because of this particular pathology, and that results in compression of the nerves, especially of the brainstem and all. So they will be having this neurological compromise during their lifetime. Okay. Now another thing, Vermian bones. So what are these Vermian bones, by the way? These Vermian bones are the intrasutural bones. Actually, it could be a few number, can be also idiopathic or can be seen normally also. But otherwise, Vermian bones are seen in. So again, there is a mnemonic. I think I have put it. Anyways, in these cases, except for hypoparathyroidism, pycnodysostosис, rickets, and hypothyroidism, can show this Vermian bones. Okay, there are n number of causes. Okay, so these are Vermian bones which are intrasutural. They are located within the sutures, in the lambdoid suture, in the sagittal suture. So this is what is called as the Vermian bones. Okay. Yes. So this is a mnemonic, that is pork chops, which can produce Vermian bones. I know this is a lot. At least remember a few. That is pycnodysostosис, osteogenesis imperfecta in rickets, cleidocranial dysostosis, hypothyroidism, and in trisomy 21. So all these conditions can cause Vermian bones. So yes, this is one of these conditions. Among this lot, I have put one particular condition. So yeah, this is the Vermian bones that I was talking about. Now, do you know what is this condition? So there is something which is absent here. Comparing with a normal radiograph, some particular one bone is absent here. That is the clavicle. And this condition is called as cleidocranial dysostosis. Okay, so in CCD, also we will get this condition called as Vermian bones. Okay. Now we will see onion peel appearance. So onion peel appearance is actually this multi-lamellated periosteal reaction. The importance of this onion, actually, now when I look into it, this particular radiograph is also showing one more periosteal reaction. See this, the elevated periosteum, which you can see here. This and this part is the onion peel appearance that we are talking about, and this one is the Codman triangle. Okay, that elevated appearance of the periosteum. So this lamellated appearance of the periosteal reaction, that is called as the onion peel appearance. The important thing to know is this particular periosteal reaction is a very aggressive periosteal reaction, which means there is an aggressive lesion which is happening inside the bone, and that is resulting in this periosteal reaction. When we say that there is an aggressive lesion, it depends on so many different things. So here you can see that there is a permeative lesion which is present in the shaft of this bone, or in the diaphyseal region of this bone. Okay, this is the femur. So in the femur, there is this permeative lesion which is having a wide zone. You are not able to make out the margins of this lesion, right? Somewhere all this lesion is here. We can just say that somewhere something is happening here, but that doesn't look good because it doesn't have a narrow zone of transition. In other words, a wide zone of transition is a feature of aggressiveness. Similarly, there are certain periosteal patterns which also help us to say that it is going to be an aggressive lesion. One being this onion peel appearance. Okay, this multilamellated appearance of the periosteum. So also the Codman triangle also points that this is a periosteal. This is an aggressive periosteal reaction, right? So in this particular case, when you hear onion peel appearance, this is going to be a case of Ewing's sarcoma. Actually, this can be seen with any other aggressive lesion also, like in osteosarcoma, maybe also you can get it, but then typically this is linked with an Ewing's sarcoma. Also, Ewing's sarcoma is the lesion which is seen within the diaphyseal region of a bone, long bone. Okay, whereas osteogenic sarcoma, it is more commonly in the metaphyseal region. Also, the presence of a soft tissue, that also suggests that it is going to be an aggressive lesion. And another, beware that by aggressiveness of a lesion, we just mean that it is aggressive. It need not be always a malignant lesion which is aggressive, or in other words, a benign lesion like an osteomyelitis, like a bone infection, can also be having a aggressive picture. So remember that in your mind. Now, there is another periosteal reaction which is also considered to be aggressive. That is the sunburst appearance. Okay, so here also the periosteum, the particular lesion is so aggressive that the periosteum is not able to get calcified. So what happens is that there is so many bony spicules which are arranged in this perpendicular orientation. So here there is this sclerotic lesion that is involving the lower part of the fibula. Also, it is extending into the distal part of the tibia even. And then there is a large soft tissue swelling which can be seen associated. Also, this lesion is having a wide zone of transition. So there are so many other pointers which also tells that this lesion is aggressive. And also this periosteal. In addition, there is this periosteal reaction. This is called as a sunburst periosteal reaction. Again, this could be seen it could be seen in an aggressive lesion. It need not be always an osteogenic sarcoma. Having said that, the answer is osteogenic sarcoma because it is most commonly associated with, or typically it is associated with, an osteogenic sarcoma. Okay, now the multiple punched out holes in skull are seen in which of this condition? In hyperparathyroidism, we already saw what is called as a salt and pepper skull. So in thalassemia major also we saw some particular appearance, right? So this is what is called as a raindrop skull. Okay, so it looks like the raindrops have splattered. It looks very well-defined punched out lesions of varying sizes. It is involving the mandible also, if you can see here. It is involving the skull bone. Okay, it is involving the calvarium. So this is how a multiple myeloma skull involvement will look like. Okay, so this is the raindrop. That is the term which is given, the raindrop appearance of the skull. Yeah, that is the multiple myeloma here. Now we will move to the Maffucci syndrome. So in case of Maffucci syndrome, it is associated with. So, oh, sorry, already the answer is shown here. So anyway, the Maffucci syndrome actually is a condition where there are multiple enchondromas. The enchondromas are normally classically seen within the short tubular bones of hands and feet. Along with that, when there are soft tissue hemangiomas, then it is called as the Maffucci syndrome. Whereas if you're just getting multiple enchondromas alone, then it is called as an Ollier syndrome. Okay, then when there are multiple exostoses, that condition is called as diaphyseal eclasis. So the thing with all these particular pathologies is that this enchondromas otherwise is a benign pathology, but then there is a chance of the chondroid lesions can develop or convert into, they can transform into a sarcoma. It can convert into a chondrosarcoma. So with Maffucci syndrome, with diaphyseal eclasis, with Ollier syndrome, all these conditions do have an increased risk of this malignant sarcomatous conversion into a chondrosarcoma compared with a single enchondroma. There could be a single solitary enchondroma also, but when it is associated with these syndromes, especially in Maffucci, it has got as high as 25% risk. In Oleus also, it is having like 10% risk. Multiple exhaustos is also having around 20% risk of this malignant transformation. So okay, so this is how this Maffucci is going to look like. So you can see that there is multiple lytic lesions, which is seen in multiple tubular bones of the hand. Okay, predominantly in the index finger as well as in the middle finger, there are multiple these lytic lesions, very with a relatively narrow zone of transition. Some of them having the sclerotic margins also. Apart from that, there is some soft tissue swelling which can be seen in the index finger as well as in the thumb also. And then you can see the presence of some soft tissue calcification, which tells that this could be a soft tissue vascular malformation as a hemangioma, right? So this is because of this enchondroma alone. Enchondromas can also show these punctate arcs, bits of calcifications, but these are located within the soft tissues, and that is a soft tissue hemangioma. Otherwise, this is a Maffucci. Now coming to fraying at the end of long bones is seen. And so by the term fraying itself, we know what is going to be the answer, right? So just put this question so that we can just see how this radiograph will look like. So fraying at the long ends of the long bone is seen in rickets. So we know that it is because of the vitamin A deficiency. Vitamin D is important for the mineralization of this growth plates, these cartilaginous growth plates at the ends of the bone, and it has to get it incorporated into the metaphysis. But what happens here is it is not happening, and this metaphysis, this is the metaphyseal part. The metaphysis has got this irregular appearance, and that is what is meant by fraying. Also, the cartilaginous growth plate will give a lot of stress on this metaphysis, which result in this cupping and this splayed appearance of the metaphysis. Okay, even here also you can see these arrows are pointing towards these features, and once there is treatment, you will start to see some areas of calcifications developing within the this growth plates. Okay. Okay. So, apart from this, what are the some other findings, if you ask, seen with rickets? So, there are these skeletal findings, which is called as a rachitic rosary, which occurs along the anterior ends of the ribs at the costochondral junctions, which looks bulbous and it looks like a rosary. So, that is called as a rachitic rosary. Similarly, there is something which is called as a Harrison sulcus, and then something which is also there can be a pigeon chest where the sternum is depressed inside, which is called as pectus carinatum. And then apart from that, just look at the proximal humeri. They also show these features of fraying. Okay, so this is basically a case of rickets. Now coming to looser zone. So these looser zones, okay, let me put this picture. So these looser zones, they are seen as these lucent areas. They have got certain particular locations where they are seen. One being the medial aspect of the femoral neck, other one being the axillary border of the scapula, in the superior rami, in the inferior pubic rami. So these are certain locations where you can get this looser zone. So actually these are some insufficiency fractures. It is most commonly seen associated with the osteomalacia, but it can be seen whenever there is a bone pathology. And the thing, how do you say that this is a looser zone? So this looser zone, it is perpendicular to the long axis of the bone or to this particular cortex. It is not going through and through. It is not. It is partially going through it, and it has got a sclerotic rim surrounding it. Okay. So it can be seen in all these conditions. Okay, so here also there is this looser zone you are seeing. Typically, it is one of the classical location that is at the medial femoral neck. Okay, so that is one location where you can get it. Apart from that, you can see the axillary border of the scapula, the pubic rami. Remember these locations also. Okay, now with that, we will see some important findings in scurvy. In scurvy, the Wimberger sign is best seen in. So to see the best seen location is the lower end of the femur. So this is the first we will see a diagrammatic representation of the radiological features in scurvy. So this is the epiphysis. So the epiphysis will become loosened, which is called as the okay, there is this the loosened epiphysis, and then there is this ring epiphysis, which is called as a Wimberger ring. And then there is this metaphysis, which shows this dense zone of calcification. Just near to this, there is this rarefaction, which is called as a Trommerfeld zone. And then you may see this what is called as the Pelkin spurs, and there can be subperiosteal hemorrhage. So in scurvy, there is vitamin C deficiency. It is required for the cross-linking of some amino acid residues. So that is what happens with scurvy. Okay, and okay, so these are radiographs which is showing all these findings of this Wimberger sign, Wimberger ring. Then there is this dense zone of calcification, the Trommerfeld zone that you can see here. There is this periosteal reaction, which has happened because of the subperiosteal hemorrhage that is happening. Okay, this one is also showing all these findings, and the subperiosteal hemorrhage, which is causing very large soft tissue opacity along the length of this femur. Okay, so next coming to another condition, that is tram-line calcifications are seen in which of this condition? So tram-line calcification is something which is seen in a skull radiograph, but we do not usually, that was a long time before a skull radiograph was done, maybe for academical purposes, but otherwise tram-line calcification is seen in a radiograph because of this gyriform cortical calcifications, which happens in Sturge-Weber syndrome. So this is the tram-line calcifications that we are talking about. So in Sturge-Weber syndrome, we know that there is pile angiomas, which is along the ophthalmic division of the trigeminal nerve. So they will be having this nevus, and then they will be having this these angiomas, the pile angiomas, and these pile angiomas will cause shunting of the blood from the cerebral circulation. So these patients will present with cerebral atrophy. They will be having hemiplegia. They will be having seizures. Then there can be also calvarial hyperostosis. There can be there is enlargement of the paranasal sinuses. So these are the features of the Sturge-Weber syndrome. Okay. Okay, now the investigation of choice in acute osteomyelitis is. So the investigation of choice, just like that avascular necrosis that we have discussed, in a case of an acute osteomyelitis, it is the MRI that is going to show the initial findings of the marrow edema and all. So that is going to help you. So that is MRI, which is the investigation of choice. Now, the calcification of the intervertebral disc is present. So this is the region of the intervertebral disc, and normally this should appear loosened because of the cartilage. But then what has happened here is there is calcifications of this disc area, and this happens with ochronosis or the alkaptonuria, where there is homogenesic acid which is accumulating, and that also result in this dark coloration of the urine. There will be the napkins which will be also discolored. So that is a finding, that is a skeletal radiographic finding that you can see in ochronosis. Now, what is meant by scivora? Scivora is actually spinal cord injury with okay, so basically scivora is a condition where there is spinal cord injury without radiographic abnormality, which means that okay, you are suspecting a neurological deficit in an individual, but then you are not there is no evidence of any fractures or any radiographic with a radiograph, with a X-ray, you're not able to find anything. There is nothing, it looks normal. So that is what is called as scivora. And with scivora, it also tells that this patient might need an MRI because the spinal cord related findings will not be seen in SCT, will not be seen with the radiograph. So especially in the pediatric population, this particular terminology is existent. And whenever we have a suspicion of a spinal cord injury, we have to take the patient for an MRI. So that is what is meant by scivora, spinal cord injury without a radiographic abnormality. So the radiograph is normal, but there is a neurological compromise, which could be because of a spinal cord injury. Okay. Which of the following usually produces osteoblastic secondaries? So actually, let me say that all these options, all these conditions can cause osteoblastic secondaries, but usually it would be the carcinoma prostate, right? So a carcinoma lung, especially with a small cell carcinoma, they can produce osteoblastic mets. A carcinoma breast, it can produce mixed, both osteolytic, osteosclerotic both types of metastasis can be there. With transitional cell carcinomas, that is the CA urinary bladder, they can also produce the osteoblastic secondaries. Okay, now, okay, so this particular question, geographic lytic lesion in the skull vault with beveled edges are seen with. So again, this is some sort of a buzzword that you have to identify from this question. And even if you don't know how this lesion is looking like, you don't know anything about it, this beveled lesion and this geographic lytic lesion, these two terms come with eosinophilic granuloma. Just like we discussed the vertebra plana in a kid, that is going to be an eosinophilic granuloma. Just like that, the beveled margins and the geographic lytic lesion in a child, think about eosinophilic granuloma. Okay. Okay. But in a child, especially if they are telling that the child is having an abdominal mass and this is the skull X-ray, what you are suspecting or what could be this? Always think about a neuroblastoma metastasis. And this is not looking like the previous radiograph. Here, this is a CT, obviously. And then here there is also some aggressive speculated periosteal reaction, and there are multiple lesions also. Also, there is soft tissue swelling associated with this condition, and this is neuroblastoma secondary. So, especially in a child, abdominal mass, skull X-ray showing this, or a CT showing this, what you are considering. This is going to be a metastasis from a neuroblastoma. Okay, and now this is another condition. Okay, this is another condition. Here, what has happened is there is calvarial thickening, and when you compare the outer table and the inner table is more thickened than the outer table. Also, when you look into the calvarium, there are multiple foci of sclerotic areas, which is looking like a cotton bowl appearance. Okay, so this is what is called as the cotton bowl appearance. Apart from that, there is calvarial thickening, and there is more involvement of the inner table compared to the outer table. And this particular condition is associated with Paget's disease. Paget's disease is mostly a disease of an elderly male population, and there are so many named terms. Like there will be sometimes the question will be designed in this way. The patient is having again, because of this, they can also be having cranial nerve symptoms because of the compression of the foramina, the skull foramina. Apart from that, they will be having what is called as a tam or chanter appearance because of falling forehead like appearance. They will be also having repeated changes in their head size. Okay, so all these conditions are associated with Paget's disease. Okay, so this is the Paget disease of the skull. Sometimes it may be seen here. There are actually, this has got different stages. So in one of the stage, you will get this what is called as a cotton wool appearance. Sometimes there will be a single lesion. So in a single lesion, that is called as osteoporosis circumscripta. Okay, so that is also seen with Paget's disease. Whereas when it is an elderly or an adult patient for that matter, and when you are seeing multiple lesions in the skull bone, varying sizes, think about these two conditions, metastasis or multiple myeloma. It is going to be either of that. Okay. Okay, so this is multiple myeloma, and this is a case of a metastasis. But always you have to think about both these conditions. In real life situations, you need to think in an adult, think about metastasis or myeloma when you are seeing multiple lesions in the skull vault in an adult patient. Again, a case of a metastasis. Now, this is a fracture eponym. What is this fracture name? Okay, so what has happened here is there is fracture of the proximal ulna. That is quite evident. There is also some dislocation which has happened. I mean, there is also some displacement which has happened, right? So, okay, so that is very evident, but it is not just that. There is also the radial head dislocation which has happened here. So this combination of this fracture dislocation is called as what is called as the Monteggia fracture dislocation. So that is Monteggia fracture dislocation, whereas in Lisfranc fracture dislocation that happens in the foot between the talus and the metatarsal bone. When there is fracture dislocation, that is called as a Lisfranc injury. And the Smith fracture is at the distal end of the radius with a volar angulation. It is reverse Colles fracture. Okay, and then I think I have a okay, so this is the other one, that is the Galliaceae. In the Galliaceae, the fracture is occurring at the distal radius, and there is disarticulation at the distal radioulnar joint, dislocation of the distal radioulnar joint. That is a Galliaceae fracture. And then next radiograph, okay, what is shown here? So actually what is shown here, there is an increased density within this particular bone, okay? And which is this bone? This is the lunate, okay? So this is scaphoid over here and this is the lunate. So this increased lucency in the lunate bone is because of its osteonecrosis, and that is given a name called as the Kienbock disease. The Freiberg infraction, it happens in the metatarsal bones of the foot, in the second and third metatarsal head when it is getting flattened. It appears to be flattened. That is called as a Freiberg infraction. Preser disease is the similar thing, osteonecrosis that is happening at the scaphoid. And Sevier's disease is when there is calcaneal epiphysitis. Okay. With that, let's move to trauma and emergency cases. Okay. So extradural, okay, I'll just take you through a few images to make you familiar with how these extra-axial hemorrhages will look like. So we need to go through is EDH, SDH, and also subarachnoid hemorrhages. So extradural hematoma, CT scan finding is what? So basically, extradural hemorrhage is outside the dura mater. It is just underneath the skull, and it is just outside the dura mater. So this looks as a biconvex lesion. So biconvex lesion, there are two options. Is it hyper or hypo? So hematomas in the CT, in the acute phase, it looks hyper, it looks white. So that is hyperdense biconvex lesion. So this is an extradural hemorrhage on the right side, and it is seen to be biconvex in shape. Okay, so it is usually associated with skull fracture. So when there is a skull fracture, always be on a lookout for the extradural hemorrhage. And why does otherwise? What is the most common source of bleed in case of an EDH? It is from the torn middle meningeal artery. That is one thing you have to remember. And another thing is that extradural hemorrhages, they do not usually cross the sutures. Okay, at the level of the sutures, they get limited by these sutures. But if a fracture has caused a diastasis of the suture, then it may extend beyond the suture also. Then extradural hemorrhages can cross the midline. Okay. So remember these 2 points, 3 points, I would say. One is this lens shape or biconvex. Then extradural hemorrhage can cross the midline. Extradural hemorrhage cannot cross the sutures. That is the dictum. But when there is a sutural diastasis, it may cross. Okay. But when we talk about the common appearance, it will not be crossing the sutures. Okay, so yeah, here there is an extradural hemorrhage, which is evident by the shape of this lesion. It's an acute EDH, and it is on the left side, but it is seen to cross the coronal suture. Here the coronal suture is showing some separation, which is because of the fracture which is passing through the suture line. And for this reason, this ADH has crossed it. Otherwise, it wouldn't cross it. Okay. Okay, so this again shows this fracture which has happened. Okay, so this is this pictorial representation. So this fracture, there is bleeding that has occurred, and it is from a middle meningeal artery commonly. Okay, whereas in subdural hemorrhage, the location is just underneath the dura mater. Okay, it is just underneath the dura mater or between the dura mater and the arachnoid mater. And the common source of bleeding is basically from the bridging cortical veins. So the bridging cortical veins, when they rupture, you get a venous bleed. And that is why we get a subdural hemorrhage. And they do not look like a lens, but instead they looks like it is looking like a crescent. So that is how they will look like, a crescentic hyperdensity. That is how they will appear in CTs, and they can cross the sutures because they are within the suture line. So they can definitely cross when a place where there is suture, but they are limited by these reflections of the dura mater. So they will not be crossing the midline. Okay, so just the opposite. 3 important points, how they look like. Will they cross the midline? SDH, they will not cross the midline. Will they cross the sutures? Yes, they can cross the sutures. And the subarachnoid hemorrhage, now they are located within the subarachnoid space, and they will be seen like, they will not be having this defined shape. They will be looking like, they will be just following the sulci. They will be following the contour of the sulci. So that is how they will appear. Okay. Okay, so, okay, I have put these images. Okay, in these, this is showing extradural hemorrhage. And here you can see a thin subdural hemorrhage, and also you can see the subarachnoid hemorrhages, okay, which is seen through the sulcal spaces. Okay, so that is how they appear. Okay, subarachnoid hemorrhage. Subarachnoid hemorrhage is there. Along with that, you can also see a subdural hemorrhage, which is very thin. And this one shows the extradural hemorrhage. Because of its shape, you can tell that. the most common location of a hypertensive intracranial hemorrhages. So when it comes to the intracranial hemorrhage, when it is a non-traumatic intracranial hemorrhage, the most common cause, one of the most common cause would be the hypertensive bleed. Okay, so the most common location is actually the basal ganglia. It can also occur within the brainstem and all, but the most thalami, brainstem, basal ganglia, these are the favored locations for the hypertensive bleed. And this is a CT image that is showing the bleed within the location of the basal ganglia. Not just that, here there is also bleed within the pons. Apart from that, the bleed has extended into the ventricular system, and it has reached up to the fourth ventricle. It has resulted in an obstructive hydrocephalus, because the ventricles, you can see that they are dilated because of the obstructive component. There is a hydrocephalus which has developed in this case. Okay. So a few words about non-traumatic intracerebral hemorrhage. So it could be spontaneous, as in a hypertensive microangiopathy or a cerebral amyloid angiopathy. Secondary is when there is some structural lesions which is bleeding. It could be an infarct which has undergone hemorrhagic transformation, vascular malformations, tumors, cerebral venous thrombosis, or a bleeding diathesis. These can also result in secondary hemorrhage. Now, the most common cause of a subarachnoid hemorrhages. When it comes to a subarachnoid hemorrhage, the most common cause is an aneurysm. Hypertension commonly presents in these particular typical locations. They will present as intracerebral, the cerebral parenchymal hemorrhage, whereas subarachnoid hemorrhage, mostly it is from an aneurysm. Okay. Now, the patient who had a road traffic accident, he has a loss of consciousness. In CT, there is multiple spotty hemorrhages and full basal. So the basal systems are all looking normal, but then there are small spots of hemorrhages. So the hemorrhage size is not looking as big as we expect for a patient with a loss of consciousness. There is only few small hemorrhages which are seen. So what is this condition actually? This is diffuse axonal injury. So this diffuse axonal injury is actually a shearing injury which is happening when there is a sudden deceleration. So this is typically they will occur at the gray white matter junctions. And some other locations will be the corpus callosum. So there also you can get these findings. So the diffuse axonal injury might not be well appreciated in a CT because they will be very spotty small hemorrhages. So it may go overlooked also. But in MRI, there is this specific sequence which can identify small foci of hemorrhage. So the diffuse axonal injury will be identified easily with an MRI in this susceptibility weighted imaging sequence, which will show these multiple foci of blooming. Okay, as in this case, there is multiple. Okay, this is what we call as blooming. This is because of these micro hemorrhages, and they are seen at the gray white matter junction. Apart from that, this is also located in the region of the corpus callosum. Sometimes it might not be even seen as a hemorrhagic foci. There will be some flare hyperintensity which is present in a T2 weighted sequence. Okay, so that is about the diffuse axonal injury and how they will appear. Okay. Now, in a temporal bone fracture, which is the best investigation. So for that matter, in a trauma, when you are expecting a fracture, it is going to be what? It is a simple question. I think it is a CT. Okay. For the evaluation of a blunt trauma abdomen, which of the following imaging modalities is ideal? Okay, just note the term ideal. So when you, okay, which is the ideal imaging is the what is being asked, or the imaging investigation of choice. So that would be a CT. Okay, CT is going to be the investigation of choice because it can find out small amount of fluid. It can find out the presence of lacerations, contusions. All these things can be identified with the CT. So, oh yeah, that is the CT, which is the answer. But when it comes to an emergency setup, ultrasound does have a role in a blunt abdominal trauma triaging. So that is with FAST. So every single word is important in what is the definition of FAST. It is the focused assessment with sonography for trauma. So we are just assessing. It is a focused assessment so as to identify if there is a large volume peritoneum, if there is a cardiac tamponade which has happened. We are basically looking for the presence of blood. And how do we do it? We do have different views. Okay, basically there is FAST and E-FAST. E-FAST is extended fast when we also assess two more things. Okay, when we are assessing for the presence of pneumothorax, basically. So then it is called as E-FAST. Okay, FAST and E-FAST, that is it. So in FAST, the views will be, let me go to that picture. Okay, so in the FAST, so the first image, it shows the FAST. So there is this subxiphoid view. Here we are looking into the pericardium and look to see if there is any fluid surrounding in the pericardium. That means in the context of trauma, we're thinking about cardiac tamponade. Then we will go into the right flank. Okay, from the right flank, you will be looking into the hepatorenal pouch region and seeing if there is some fluid there. In the left flank also, you are doing the same thing to see if there is some fluid surrounding the spleen. Okay. Apart from that, when you are looking at this particular right flank or in the left flank, you will be also checking above the diaphragm to see if there is a hemothorax. Okay. Or also on the left side, you can see if there is a hemothorax. Then there is this pelvic view in order to see if there is some fluid within the pelvis. So this is how a fast is conducted. Now in E-fast, what we do is we also look into this mid-clavicular region to see in the intercostal spaces to look for the presence of the lung sliding. So lung sliding is a normal finding. If there is no lung sliding, it says that there is a pneumothorax. So this also helps. In a longitudinal fashion, each of these intercostal spaces is interrogated on the right side and the left side, and then we will see if there is a lung sliding happening. Also in the anterior axillary area also this can be done. So either in the mid-clavicular region and in the anterior axillary region also this is done. Okay. Okay, so this is a view from the right flank. Okay, so this is a view from the right flank, and here you can see that there is, okay, let me guide you through this image first of all. So this is a sagittal view. This is anterior, this is posterior part of the patient. Okay, this is the cranial part of the patient, which means the patient is lying with his head on this area. His legs are on this part. Okay, so this is cranial, this is caudal. And what you're seeing here is the liver. This is the liver that you are seeing here. This is the diaphragm that you are seeing here. And this is basically the pleural cavity. So normally, we will not see the pleural cavity. We will not see basically the pleural cavity in this case has fluid within. And the fluid will be seen, the fluid, the bile, urine, everything will be seen as black in a ultrasound. That is what we call as no echoes, that is anechoic. Okay, so that is anechoic appearance, and this suggests that there is fluid in the pleural cavity. In the context of trauma, it should be a hemothorax. Right. Now, this is the subxiphoid view for the pericardium, and it shows this is the chambers of the heart, and this is showing the pericardial fluid, which is cardiac tamponade. And again, this is the right flank view in which you are also looking at the lower part of the liver. This is the liver, the inferior part of the liver. This is the kidney, the right kidney that you're seeing here. And this is the hepatorenal pouch. So it shows that there is fluid in the Morison's pouch and with a lot of echoes over here. So it says that there is hemoperitoneum. Okay, so that is about fast and E-fast. Okay, which of the following is not true about a non-contrast, that is plain CT scan in a head injury? Subdural hematoma increase in density in CT scans over week. No, a hematoma is going to decrease in its density. That means initially it looks more denser, and then because when the blood products disintegrate, it becomes more isodense to the cortex, and then it becomes more like a fluid density. It becomes more similar to a fluid density. It becomes more black in color. Extradural hematomas are usually lens-shaped. So now you know that. Acute subdural hematoma appears as a crescentic shadow of increased density. Yes. Subarachnoid hemorrhage appears as areas of increased density in the basilar cisterns. Yes, that's also true. So the wrong statement is the A. Okay, so let's see that. So this is a subdural hemorrhage that you're seeing here. It is acute, and that is why it is appearing to be hyperdense. Whereas in this particular case, you are not able to see something evidently as seen in the first image on the left side. But definitely, these two cerebral hemispheres doesn't look similar. One thing, there is midline shift. See, this lateral ventricle has gone to the left side. There is a midline shift. Also, here you can see somewhat the sulcal gyral differentiation is somewhat same, but then these are effaced over this part. It is because there is an isodense subdural hemorrhage which is present in the right side. Okay, so that is how a subacute SDH will look like. And in the third image, it is more or less chronic in nature, and hence it has become lesser dense. It has not reached up to the density of the CSF, which is still darker than the blood for sure, but then it is more of chronic nature because it has shifted from this iso density. It has become more hypodense. Okay. Now, in this particular case, there is bilateral SDH. It is having this crescentic appearance, but it has got the leveling with a density in its dependent part. It is because of an acute bleed which has happened within a subacute SDH. So that is how it will appear. Okay, so this is an acute on a subacute SDH, or maybe an acute on a chronic also. Okay. So with that, let's move to a few questions from GIT. Let me just check the time. Okay, so it's already 8:20. Okay, now let's see this cases from GIT. So first we will see the rat tail appearance. So this is a barium swallow of the upper GI. It is a contrast examination of the upper part of the GI system. Okay, so basically we are seeing a contrast filled esophagus. But what has happened in this case? The esophagus appears to be abnormally dilated over here, and then distally it is showing a narrowed appearance, a stricture-like appearance is seen, and this looks like a tail of a rat. Okay, so this happens in apart from that, it is also very irregular in its nature, and also there is this shouldering. It looks like a shoulder. This is what is called as shouldering, and this should ring a bell, and this is very suspicious for a carcinoma esophagus. So the rat tail appearance is seen in carcinoma esophagus, but in the same setting, I would also like to explain to you about eclasia cardia as well as the hiatus hernia, how they will, because these two conditions do have very typical appearances in a contrast study. Okay, so yeah, that was a carcinoma esophagus of the lower esophagus, and that is resulting in this narrowing of the lumen, which has resulted in this rat tail appearance. Whereas, just contrast with this case. Okay, here also you are seeing the narrowing of the distal part of the esophagus, but it doesn't look similar to a rat tail. And this is what is called as a bird beak appearance. This is more smooth in appearance. The tapering is there, but then this tapering is more smooth. Okay, so this is because of this is a echinacea cardia. Okay, so this is echinacea cardia, bird's beak appearance, and the rat tail appearance, which happens with carcinoma esophagus. Okay, so here there is abnormal relaxation of the lower esophageal sphincter. Okay, and then echinacea cardia, there was dysphagia to both solids and liquids. Whereas when it comes to a carcinoma esophagus, it is more towards the solids. Okay, the dysphagia is more towards solids, whereas in here, when there is a neurological pathology, a neurological abnormality, there will be dysphagia to both solids and liquids. Okay, and there is proximal dilatation of the esophagus, proximal holdup of contrast because it is not smoothly passing into the stomach. So there will be absence of the normal primary peristaltic wave. There will be abnormal tertiary peristalsis. All these things will happen. So anyway, for your matter, I would say rat tail, carcinoma esophagus, and bird's beak, what happens in echinacea cardia. And this is what is happening. Okay. Yes, and then what is this radiograph telling you? So here in this radiograph, okay, whenever you're looking into a radiograph, we have to see it in a systematic fashion so as to not miss some important regions of the radiograph where there is an abnormality which is not very evident. So if there is an evident mass, everyone can see it. So we should be looking it should be so that you are not missing any area. Okay, you need to look into the skeleton, you need to look into the rib cage, into the thoracic cage. You need to look the trachea. You need to look the lung fields. You need to just compare the lung fields one from other. And then after looking all these things, you need to look into the heart size and all. You need to look into the diaphragm. All these things you have to see. You also have to look into the breast shadows if they are present or not. Look into the outermost part of the radiograph. Sometimes there will be a lesion in the head of the humerus which is otherwise missed. Okay, so all these things should be looked for. You look into this neck. Sometimes there will be the soft tissue swelling in the region of this neck. So all these things can happen. Now, what has happened after looking all these areas? There are some hidden areas in the chest X-ray which you have to look. One is the lung abscesses. There may be something which is hiding in these lung abscesses that you have to check. Then you look into the lung hilum. Okay, sometimes there will be a hilar mass which you have totally missed. So look into that. Then you look below the diaphragm. Sometimes there will be this thing that is air under diaphragm which you have totally missed. So then you look behind the heart also. So sometimes there will be an opacity. So here there is an opacity which is seen behind the heart. Okay, it is a retrocardiac opacity. Not just that there is a retrocardiac opacity, it is showing a air fluid level also. This appearance is very typical of a hiatus hernia. So this is a case of a hiatus hernia. Okay, I have also put another image. So when there is, in case of hiatus hernia, the dilated esophagus commonly lies to the right side of the chest. So this paracardiac large linear opacity, which you are seeing here, it is not obscuring the cardiac border. And now if you go superiorly, you can see that here there is an air fluid level. So this air fluid level, the long paracardiac opacity And also look for the stomach bubble. Okay, so this is a small stomach bubble. I think in the previous case, there is no stomach bubble. So all these are pointers towards the achalasia cardia. Apart from that, in this lateral view, you can see that this trachea, it is compressed and it is pushed anteriorly by this dilated esophagus. Okay, so I mean, by this hiatus hernia. So this is a case of hiatus hernia. Okay. Now, this is a barium swallow, okay? It is an inverted image. That is why the contrast is seen in black in color, okay? So the barium swallow who presented with dysphagia and regurgitation, what does it show? So first of all, this is a lateral view, okay? So this is lateral view in that this is anterior, this is posterior. So definitely this is not very normal, right? So there is a contrast fill out pouching, which has happened from the region of the cricopharyngeal level, okay? So typically at the C5, C6 level, it is going posteriorly. So this posterior location in the lateral view of a barium swallow is typical of the Zenger's diverticulum. It is a pulsion diverticulum which is occurring through this what is called as a Killian dehiscence. Okay, Killian dehiscence has nothing to do with the Killian diverticulum, mind you. The Zenger's diverticulum occurs through this weakening. It is a anatomical weakening which is present within the inferior constrictor muscle, the Killian dehiscence. So through this dehiscence, this outpouching has happened. It can result in the regurgitation of the food substances also. So that is a Zenger's diverticulum which is seen. That is above the level of the upper esophageal constrict, the sphincter. Okay. Now, whereas this is a AP view only, and here in this AP view, again a lateral outpouching is seen from the very beginning of the cervical esophagus, just below the level of the cricopharyngeus, and this is how a Killian diverticulum will look like. Okay, so just to make you familiar with a Zenger's diverticulum, lateral view, it is posterior. So you can make that out in a lateral view only. The lateral view will show that it is located in the posterior part, and in a frontal view you cannot say that whether it is posterior or not, but this is lateral. In a frontal view you cannot say whether that is posterior or anterior. In this frontal view you are seeing a lateral outpouching which is seen and slightly at a lower level also. So this is a Killian's diverticulum. Okay. Now, what is a dye which is used in esophageal perforation? So in a suspected case of an esophageal perforation, when we need to perform a study, when we have to make the patient drink something in order to identify maybe from where the perforation is happening and all, which is the dye which is used. So in such situations, it is the iohexol. It is an iodinated contrast agent. So in such situations, iohexol is preferred. Gastrographin is an agent that is commonly used for these procedures, but normally it is used, especially in CTs and all, as a positive contrast agent. But then gastrographin, even though it is water soluble, it can cause there is a risk of aspiration and it can result in pulmonary edema, so it is not used. Barium, through a perforation, it can go out, and when it leaks, it can produce mediastinitis. So whenever there is a suspicion of a tracheoesophageal fistula, esophageal perforation, or a perforation peritonitis, barium is not used. Okay, it can produce peritonitis, mediastinitis, etc. Okay. Now, what is the most probable diagnosis? So this is a very simple, straightforward radiograph which shows air under diaphragm, and that is seen with the pneumoperitoneum. Okay. Okay, so that is pneumoperitoneum. Okay, so pneumoperitoneum can happen because of all these causes. Basically, when there is a bowel perforation, which can happen in all these conditions. And if you are asked what is the most important useful plain radiograph for diagnosing a pneumoperitoneum, it is not an abdominal X-ray, mind you. It is an erect chest X-ray, because the erect chest X-ray will include this part, and that will show you the pneumoperitoneum. Erect X-ray is important. And if it is very minimal pneumoperitoneum, what we can do is, in order to demonstrate the minimal amount of air in the peritoneal cavity, a left lateral decubitus abdomen with a horizontal beam is performed. So what happens is that the patient lies down on his left side of the abdomen. The patient is lying down so that air will go up, and this air will line the liver surface. So it will be seen well with a horizontal beam radiograph. So that is why we perform a left lateral decubitus in a patient who is suspected to have a minimal pneumoperitoneum. But then Okay, if you're suspecting a pneumoperitoneum, nobody is going to take all these things. Instead, he will be taken for CT. So the best investigation is going to be CT abdomen. But the most useful plain radiograph, if they ask you, that will be an erect chest X-ray. And in order to identify a minimal amount of pneumoperitoneum, the investigation would be to, if they want an X-ray specifically, that would be a left lateral decubitus. Okay. And then there are so many named signs with respect to this pneumoperitoneum that happens. One being this air under diaphragm. This air under diaphragm, when it is lining both the diaphragm, that will become this continuous diaphragm sign, which can be seen with pneumoperitoneum. Apart from that, with relation to the bowel wall, here what has happened is, you can see this bowel wall. This is a bowel. This is a wall of one of the bowel. You are able to make out the bowel wall very well. Why this happened? This is because there is gas inside the bowel. Now there is gas which is outside the bowel also. So because of that contrast, because of the contrast of the bowel wall with the air inside and outside, the wall is lined pretty well. Here you're not able to make out. This is actually the two walls which are opposed with each other. But here the wall is seen very well. And this particular sign is called as a Wriggler sign. And with respect to the numerous ligaments in the abdomen, which all can get lined by the pneumoperitoneum, there are so many name signs. But one important sign that you need to remember is what is called as a football sign. So this is the football sign which is seen with the pneumoperitoneum. Okay. And okay. Also, there are so many different signs. You can just check with respect to the falciform ligament sign is there, and there is something called as the cupola sign. There is called as a Doge's cap sign, and then there is this inverted V sign along the lateral umbilical ligaments. So there are different signs which have been described with pneumoperitoneum. Uh, okay, here it is seen lining the entire dome of the entire liver surface. Okay, just making a point. This is what is called as a Doge's cap sign. Okay, so this is the Doge's cap, a triangular like thing, right? And this you can see here. It is because of the air which is present in this Morrison's pouch region. It is formed by the 11th rib superiorly and by the rest of the structures. Okay, so yeah, so many fancy names are there with respect to the pneumoperitoneum. Now, what is the finding shown in this barium meal study of a smoker who presented with burning epigastric pain? Okay, so this is a gastric ulcer, and this is typically how a benign gastric ulcer would look like. So first of all, the ulcer mount, it projects beyond the lumen. That is one way of looking at it. And then there is this thin collar, which is called as the Hampton's line. Okay, so this is a Hampton's line, that is a benign gastric ulcer. Okay, and then sometimes you can see something like this, which is called as a spoke wheel pattern. So all the folds, the gastric folds are seen radiating to this area of the ulcer, and it is seen till the level of the ulcer, and it is very smooth also. So that is how a benign gastric ulcer will look like. On the other hand, if it is a malignant gastric ulcer, usually the ulcer will project into the lumen. Okay, and this appearance where it has got this convex margin of the ulcer which is pointing towards the lumen, that is called as the Karman meniscus. And so there's something which is called as the Kirklin complex, Karman meniscus, with the radiolucent semicircular zone surrounding the elevated edge together. This particular together, the whole thing is called as the Kirkland complex. Anyway, that is how this Karman CAR, carcinoma CAR. So that is one way. This Karman meniscus is associated with a malignant gastric ulcer, and the Hampton-Zumba is related with a benign gastric ulcer. So just to tabulate it, Hampton's line, benign gastric ulcer. The one that extends beyond the gastric wall, that is benign. The folds, as you have seen, that spoke wheel pattern, smooth, even. In malignant, it is going to be irregular and nodular. Then Karman meniscus, it's seen with malignant ulcer. Then the ulcer shape will be irregular when it is malignant, and it is more round, oval, and linear when it is a benign ulcer. So that's that. Now another condition, an elderly patient, buzzword, presents with abdominal distension, absolute constipation, buzzwords. The abdominal X-ray was taken. What is the diagnosis? So actually, this is a condition which is seen in these elderly patients, especially when they have constipation. So elderly patients, most of the times they will be having this constipation, chronic constipation, and this will result in what is happened here. Okay, so this is a sigmoid volvulus. So this sigmoid volvulus, so this is this dilated sigmoid that you are seeing here. And this dilated sigmoid, there is no hosta which is seen. And this is having the typical appearance called as the coffee bean-like appearance. And there is absence of the rectal gas which is seen here. There is some gas that you can see here and all, which is actually within the colon, which is in the descending colon, transverse, and in the ascending colon. There is no small bowel dilatation as such. So these are some points which will help you in telling that there is a sigmoid volvulus. Okay, so this particular appearance, definitely this what we call this coffee bean appearance, the tire-like appearance, all these are related with the sigmoid volvulus. Okay, so in case of sigmoid volvulus, really can't say that it is very emergency, because just by passing a flatus tube, this patient will be relieved of this sigmoid volvulus. Okay, so that is sigmoid volvulus. And whereas when it comes to a cecal volvulus, so here there is twisting of the cecum in its mesentery. And what happens in the cecal volvulus is that this is the cecum. And in cecal volvulus, there will be also dilated small bowel loops. Here you do not see a lot of dilated small bowel loops. Just look into this picture once again. You're not seeing any much of a dilatation in the small bowel loops, right? But here there will be a lot of dilated small bowel loops, and it will be seen even lateral to the cecum. So you just imagine the normal anatomy. In that normal anatomy, where will be the small bowel loops located? The small bowel loops are located medial to the cecum, right? The iliocecal junction, it comes medial to the cecum, right? The small bowel loops will be medially located, right? But when there is a cecal volvulus, they are seen further lateral to the cecum that has got a volvulus within. And apart from that, okay, the left side of the colon, everything is collapsed now. So here there is a volvulus, and the part of the colon beyond the cecum has now become collapsed. There is a lot of small bowel dilatation which is also seen. The small bowel loops are dilated. And also if you look into this has got this peculiar appearance like a embryo, I would say. So this is also something which is seen with cecal volvulus. Okay, so cecal volvulus is kind of an emergency. Okay, so that is sigmoid versus cecal volvulus. Just a few points. Elderly, think of sigmoid. 30 to 60 years, think of cecum. Horse trait, which is maintained when it is a cecal volvulus. Whereas it is lost in case of a sigmoid. It has got that smooth appearance. And there will be large bowel dilatation in sigmoid volvulus, whereas the colon is completely collapsed in the cecal volvulus, and the proximal bowel loops will be dilated. In sigmoid, the proximal large bowel loops are dilated, and we do not see a lot of small bowel loops. Okay, whereas in cecum, the distal loops will be collapsed. So the large bowel loops are collapsed, and then the small bowels are dilated. Okay. With that, let's also speak a bit about a small bowel versus a large bowel obstruction. So the valvulae conniventus, that appearance is seen with jejunum. Many loops are seen. When there is a small bowel obstruction, many loops will be seen. Whereas large bowel obstruction, the dilated loops will be very small. These bowels, the location is also important. Large bowel is peripherally located. Small bowel is located centrally. So also when there is an obstruction, it will be in that pattern only. Hostra, large bowel, diameter, small bowel 3 to 5 centimeters is what they can dilate up to. Large bowel, they may be seen. So very large dilated bowel, if you're seeing, think about a large bowel obstruction. Then solid feces is seen with large bowel obstruction. Okay, so this is a small bowel obstruction seen as multiple air fluid levels. So this is an erect radiograph. So if it is supine radiograph, you will not be seeing this air fluid levels. So these are not showing any air fluid levels, but then there is multiple gaseous dilated looking small bowel loops. There is paucity of gas in the rectum. So all these tells that this is a small bowel obstruction. Okay. Yeah. Now this is another case. 30-year-old lady, chronic bloody diarrhea, abdominal pain. A barium enema was done. What is the diagnosis? So what is seen here? This is a double contrast barium. And in this double contrast, okay, this is passing through the colon. What has happened to this colon? It has lost all of its horse trait. It is looking very smooth in its appearance, right? So this is what is called as a lead pipe colon. And lead pipe colon, if you are asked, you can say that it is ulcerative colitis. So there is definitely involvement of the rectum. So there is a continuous involvement. All these are features of ulcerative colitis. But also remember that ulcerative colitis, for that matter, any inflammatory bowel disease, but anyways, ulcerative colitis has got an increased risk of developing carcinoma. So whenever you see a stricture, sudden narrowing, maybe in this case also, there is a sudden narrowing over here. So this could be because of a developing carcinoma here, right? So that is ulcerative colitis led by colon and increased risk of carcinoma. Also, there is when there is involvement of the ileum, that is called as backwash ileitis. So that is with ulcerative colitis. It has got a lot of extra intestinal findings also. Okay. Now, colon cut-off sign is seen in which of these conditions? We know about sigmoid volvulus and all. Ischemic colitis, it is not a colon cut-off that you can see there. There may be thumb printing. I haven't put an image, but there is thumb printing which can be seen with ischemic colitis. Chronic pancreatitis, acute pancreatitis. So the choice is between these two, and that would be an acute pancreatitis. So what happens here is, so here you can see that the colon is dilated or distended, gaseous distension of the colon is seen, but then there is an abrupt cutoff over this part. Okay, what is this part? This is the splenic flexure. So what has happened is that the inflammation in the pancreas, the acute pancreatitis, has gone through the phrenicocholic ligament, and through the there is involvement of the phrenicocholic ligament through the transverse mesocolon, and that has resulted in what is called as a colon cutoff sign. Okay, in acute pancreatitis, the investigation of choice to assess the prognosis. In acute pancreatitis, there is a risk of so many complications can develop in acute pancreatitis by development of the necrosis of the pancreas. There can be necrotic collections which can develop. There can be pseudocyst formations. So all these, in order to assess, there can be also there can be pseudoaneurysms that develop. So in order to assess this prognosis, the prognosticate the acute pancreatitis, the investigation of choice is going to be a contrast enhanced CT study based on which there is a modified CT severity index which has been proposed, in which 0 to 3, the grading is like this. Okay. If you're interested, you can just go through a CT severity index also. Now, what is the sentinel loop sign? So sentinel loop sign says that there is something happening there. So how does this look like? So there is a focal area of a gaseous distended bowel loop where rest of the abdomen is looking without any significant abnormalities. There is this particular area which is catching your attention, and it is telling you that there is some pathology over here. So when there is a focal intra-abdominal inflammatory process, an adjacent area of bowel loops get ileus. So that result in what is called as a sentinel loop sign. Okay, so that is sentinel loop sign. I think it is 8:40. It is going to be 8:45. I hope to at least complete the GIT today. Let's see. So this is a right upper quadrant ultrasound. The patient is having recurrent history of hypochondrial pain. And what is this particular appearance? So let me guide you through this image. This is again a axial section or a transverse image through the right upper quadrant. This part is the liver that you are seeing here. Now what we are looking here is, see, there is an area of the dense shadow that you are seeing here. Just above it, there is an area of echogenicity also. So this particular condition is what is called as wall echo shadow complex seen with chronic cholecystitis. So what is this wall echo shadow? So because of this chronic calculus cholecystitis, what has happened is that the gallbladder has itself shrunken. So this wall is what you are seeing as this first hyper echo. So this part is the wall of the gallbladder. A thin lining of bile is what you are seeing as this hypoechoic part. And then there are this calcifications, which is showing as this dense shadow. So that is the wall echo shadow complex seen with chronic cholecystitis. Okay. Okay, just putting this again, the wall, that is a contracted GB that is shown echogenic. Then there is this thin layer of hypoechoic bile, and then echo from the gallstone and this shadow from the gallstones. Okay, so that is a wall echo shadow complex, right? Whereas in that, okay, question, there was something called as comet tail artifact, which is seen with, that is true, comet tail artifact is seen with adenomyomatosis. So what is adenomyomatosis is because of the deposition of cholesterol crystals in so-called this Rokitansky-Askov sinuses within the gallbladder wall. Okay, there is intramural depositions within these sinuses, and that result in what is called as these comet tail artifacts. Okay, you can see this comet tail like appearance, echogenic comet tails, right? So this is what is happening in adenomyomatosis. This appearance is called comet tail artifacts in adenomyomatosis. Okay, now a logical question. The patient has got a calcification on AP view on the right side. So that is something happening on the right side. Okay, it could be anywhere. It could be some nodes. It could be in the liver. It could be in the kidneys. It could be in the spine. Anywhere. Now, so anyway, it is in the right side. But in the it cannot be in the spine because it is on the right side. Okay. In the lateral view, this is seen to overlie the spine. So it is a posterior lesion. The most likely diagnosis is gallstone. It should come anteriorly. Calcified mesenteric nodes, it is more anteriorly. Then renal stones, yes, they can happen posteriorly. Calcification in the vertebral, I think that was a spinous process, what I meant. So no, that is not possible because it was on the right side of the abdomen. So that is a renal stone. Okay. Maybe, as in this case, this is but on the left side anyways. Anyway, on the left side and lying posteriorly. So it is in the left, it is a left renal calculi which has happened. Now, the chain of lake appearance on the X-ray. So this is also a sort of a intra-abdominal calcification, and this has got this peculiar appearance. It is distributed across the midline. It has got this slightly oblique orientation. And what is the structure which has got such an orientation? Your pancreas, and you will be expecting a chronic pancreatitis where there will be a lot of calcifications within the pancreatic parenchyma. So that is seen with chronic pancreatitis. And another a simple question, the right lobe of the liver consists of which of the following segments? So that will be 5 to 8. So they will form the right lobe of the liver. So here you can see this form the left lobe and this form the right lobe of the liver. So this is a portal vein which is dividing it superiorly, inferiorly. And these are the superior segments. These are the inferior segments. The falciform ligament that is helping to divide the left lobe to the medial segment and its lateral segments. And then there is this middle hepatic vein you can see here, which divides the right lobe from the left lobe here. And then this is the left hepatic vein, sorry, the right hepatic vein, which is dividing the posterior segments from the anterior segments of the liver. Okay. Now, a 55-year-old male has obstructive jaundice, weight loss is there, everything point towards a malignant sort of history. Now on CT was done, CBD is dilated till the lower part. Also the main pancreatic duct is dilated. This condition is called as a double duct sign. But the pancreas is appearing normal. So what is the most likely diagnosis? So with a choledocholithiasis, we do not expect the pancreatic duct to dilate. So also in carcinoma gallbladder, we do not expect this to happen. Whereas in hilar cholangiocarcinoma, you might see some IHBRD, but not see the pancreatic duct dilatation. So the periampullary carcinoma typically will produce this double duct sign. Okay. Also, a carcinoma head of the pancreas might also cause it, but then here the pancreas is normal. So it is typically the periampullary carcinoma. Okay. That is periampullary carcinoma. Now, the investigation of choice for the small intestine tumor. The investigation of choice is going to be beta meal follow-through. No, not really. For an academic purpose, it might help. USG abdomen, very difficult to pick up such lesions. X-ray abdomen also, it is not going to help. CT scan with contrast is the answer. Okay. Now, in X-ray, what is the pattern seen in jejunum? So, the pattern seen in jejunum, the jejunum has got this feathery appearance, which is called as the valvulae conniventus, whereas ileum, again, which is seen here, has got this featureless appearance. Okay, so that is valvulae. Now, the widening of the C loop of the duodenum. So this is a barium follow through. This is the C loop of the duodenum that you are seeing here. And this is diagnostic of which of this condition. So actually speaking, this can be seen in any pathology which is happening. It can be from the duodenum, it can be from the pancreas, but typically it is described for a carcinoma head of the pancreas. So that is the widening of the C loop. So this is the C loop that we are talking about, and this has got widened, which is because of the carcinoma head of the pancreas. Now, in case of acute pancreatitis, the investigation of choice, I think we already kind of discussed this. That would be a CT scan with contrast. So here there is also a plain CT scan. It is not going to help you a lot. It is going to be the post-contrast study, the CT scan with contrast. So with that, just we will move to a few questions from GUT. CT scan of a patient with acute abdomen was done, and what does this show? Okay, so this patient is having acute abdomen, and for this reason a CT abdomen was done, a contrast study was done, and what is shown here is this is the kidneys. What has happened to the kidneys? It is slightly lower in its position. Not just that, it is horseshoe kidney. So in horseshoe kidney, as you know, horseshoe kidney is a congenital fusion abnormality which happens in the kidney, and since they are fused in the midline, the inferior mesenteric artery, it kinds of further hinders with its further ascent into the abdomen. So it is typically seen at a slightly lower position. That's one thing. And horseshoe kidney has got an association with Turner syndrome, remember that. And then also these patients, they do have increased risk of developing a trauma, because it is very vulnerable for traumatic, it is very vulnerable for trauma. So trauma, increased risk of trauma, not just that, increased risk of calculi, increased risk of PUG obstruction, and there can be increased risk of malignancy even. So all these conditions have got an association with horseshoe kidney, right? And this is a nuclear study. What does this show? This is showing the horseshoe kidney. See, this is that joining across the midline that you are seeing. And this is how that appears in the ultrasound. This is the spine, and this is the isthmus, which is connecting the kidneys. Okay. And here, this is a radiograph, but what is peculiar in this radiograph, you are seeing multiple radio opacities here, which is some of them being small, some of them of varying sizes, and then you are also able to see this particular soft tissue shadow, which is kind of coming across the midline. So this is a horseshoe kidney showing calculi within, and this is an image sequence from a IVP examination. So here the contrast will be pushed through the intravenous, contrast is given, and then we will look for the functioning of the kidneys here. So here in the scout image, before the administration of the contrast itself, there is something which looks abnormal. So the normal renal shadows will be seen somewhere like over here, but here there is some abnormal shadowing which is happening here, which is crossing the midline. And once the contrast is given, it is very evidently seen that the calyces are also seen in the midline. It has got more medially located positions. So this is a horseshoe kidney. Yeah, that is called as a flower vase appearance also. Okay, this appearance is called as a flower vase appearance. Now, which one of the following is wrong regarding the adult polycystic kidney disease? So, in adult polycystic kidney disease, kidneys are enlarged in size. They are large kidneys. The presentation is unilateral? No, it is a bilateral pathology. Intracranial aneurysm, yes, they do have an association with berry aneurysms, typically seen along the third decade of life. So, the wrong statement would be it is unilateral. Okay. Now, investigation of choice, acute urethric colic. So acute urethric colic, the investigation of choice, remember it is a non-contrast, no need of a CT contrast study, a plain CT. The plain CT will show you the presence of the calculi, the density of the calculi, which is also important to decide on the treatment, the size of the calculi, the density of the calculi, where it is located. So all these can be identified, and also the possible complications. Is there any abnormalities in the renal size? All these things can be identified with a CT. So a plain CT is the investigation of choice when it comes to an acute urethric colic. Okay. In a child, non-functioning kidney, so we need to look whether the kidneys are functioning. So it is best diagnosed by ultrasonography. It will show you the morphology. It can show you any abnormalities in the number, position. All these things can be found with an ultrasound. IBU can look into the functioning of the kidney, but the question is best diagnosed by. For the best diagnosis, we need to do a nuclear study, and that would be a DTPA renogram. Whereas if you need to look for the cortical scarring in a child, that would be a DMS. I think I have included a few questions from the nuclear medicine, but that is towards the end of the presentation. Definitely, I will not be reaching that today. Maybe another day we will see a few questions from nuclear medicine as well, in which I have put some questions about this. Okay, so again, the flower vase appearance, as I was talking previously, that is seen with horseshoe kidney. Okay, so that is the flower vase appearance. Now with that, we will just move to, I think I've got like 5 minutes left. If you guys can follow, maybe we will do two more questions from chest and we will stop it and call a day. Okay, so air bronchogram is seen in. So yeah, what is air bronchogram? So this is a chest radiograph, a zoomed in image for you, and this is the left side of the hemithorax. What you're seeing here is an opacity. What is special about this opacity? You can see some tubular lucencies which is seen. This is what is called as an air bronchogram. So what is the advantage of an air bronchogram? It says that the airways are patent, and not just that, it is a parenchymal pathology. That's the first thing. It is a localizing finding when it comes to a chest radiograph. It tells you that it is a parenchymal pathology. So what is a non-parenchymal pathology? It could be from the ribs, it could be from the pleura, and all. It can be from the chest wall. So this says that this is from the lung only. So that is an air bronchogram, commonly seen with consolidation. Why that happens? The alveolar spaces, which is otherwise filled with air, as in these regions, in this particular region has been replaced. The air has got replaced with some other things. It could be pus, it could be edema, it could be blood, it could be malignancy, anything. So that is what is meant by an air bronchogram. And so that is seen with consolidation. So other findings will not show it. So sometimes collapse may show it, but then typically when we talk about an air bronchogram, we indirectly mean that there is an area of consolidation. Okay, so this is also an area of consolidation, which is seen in the left lower zone. It is obscuring the heart border, the diaphragm, which says that the pathology is likely to be in the lower lobe. This is the air bronchogram. I just have put a CT lung window image, which shows how a consolidation will look like in a CT image. And this is the bronchogram that you are seeing actually. Okay. And this is what is how it will be seen in an ultrasound of the lung. So in this ultrasound of the lung, the air, when it is replaced by the fluid, it becomes a very good medium for the very good medium for the ultrasound to pass through. And these tiny echogenic lines that you are seeing here is the sonographic bronchogram that you are seeing. Now, okay, in order to detect a left pleural effusion, which is the best position for the chest X-ray. So if it is in the left side, then the fluid will layer down, right? So we need to take a left lateral decubitus. So the left lateral decubitus, as in this case, when the patient is made to lie on the left side, the fluid will also line on the left part of left pleural cavity, and it will be seen accumulating on the chest wall region. So this is how it will be helpful to detect. Otherwise, actually, a pleural effusion to be able to be detected in a chest X-ray, it requires a large amount. It requires actually 250 to around 600 ml of fluid may be required to identify, but actually an ultrasound, on the other hand, is very sensitive in picking up pleural effusion. Anyways, if you really need a chest X-ray itself to detect the pleural effusion, then you can go for the lateral decubitus view with the side where you have the concern of pleural effusion to be lying down. Okay. Yeah, this is the ultrasound. Just remember from the previous question, one of the question, this is the diaphragm and this is the fluid that you're seeing. So that is the pleural effusion. Very small amount itself can be picked up. Okay. I think with this particular question, I might have to stop the talk. All the following are true about a located pleural effusion. So before that, let me tell how a free pleural effusion will look like. Initially, it will cause the blunting of the costophrenic ankles. And then what happens is that the fluid will layer across and it forms what is called the very famous meniscus appearance, which is laterally upsloping and it is medially downsloping. So that is how a normal effusion, free effusion will look like. But always be beware of the fact that even a very large effusion can be missed in a supine radiograph. It may just look as if there is some increased density. It will not look anything like a pleural effusion as one would expect. Okay, so that is about pleural effusion in a normal situation, a free pleural effusion, right? Whereas when it comes to a loculated pleural effusion, the loculated pleural effusion will be not having these features as a free pleural effusion. Instead, it will make a obtuse angle, as in this case, it will make an obtuse angle with the chest wall, and these margins will appear to be quite clear, and it will not be confined to any bronchopulmonary segment also. But air bronchogram is seen within the opacity. That is the wrong choice, because now you know that the air bronchogram is a finding which is seen with parenchymal opacities, parenchymal pathology. So that will not be seen with a loculated pleural effusion. So this is a loculated pleural effusion that you're seeing there, and air bronchogram is not seen in that. Just a CT coronal reformat, which is showing multiple loculated pleural effusions, and also you can see this the drainage tube which is in place. Okay, now this is somewhat a bigger topic. I don't think I can just explain to you. Okay, so with this, I think I have just run out of time, and thank you for listening. So probably we will discuss the rest of the systems, a few more systems, the chest being the larger one, in another session if it is available. Or otherwise, thank you and all the best to all of you who are writing this exam. I hope I could help you at least in some way. Thank you.